Yes. So hello everyone and welcome to the iTalks webinar powered by Mero Eye Academy. I'd like to welcome you all for the iTalks webinar session 131. We are going to have a session on restoring binocular vision. I'm signing as your host for the today's session. So I'd like to go through the introduction of our today delegates. As a speaking delegates, we have Dr. Pradeep Sharma. He is an MD, FMS, ex-professor at the AIIMS, Director Strabismus, Pediatric and Neuro-Ophthalmology Services, Center of Site, Safdarjung, Enclave, New Delhi, India. So I know you are too much eager to learn. So without further ado, I'd like to request Dr. Pradeep to share his screen. Over to you, Doctor.
Thank you, Kapil. It's a pleasure going virtually to Nepal this time. And I have been to Nepal several times earlier, and it's been a pleasure always. And this time again, and I would be talking on the subject which is dear to all of us, and especially all you students who are interested in optometry or taking care of the children's eyesight. So today the topic is restoring binocular vision. Amblyopia to Stereopsis 2021. This is the Mero Nepal expedition in order to conquer the problems of vision in children. The mission is to add color to the child's life. Let me say that I have no financial disclosures to make in any of the conditions. Stereopsis is the new goalpost for all of us. Whether we see a 3D movie or as surgeons when we are operating, we use 3D vision, or even if you are doing any other job in which you require a 3D perfection, you will require stereopsis. For all the people who are the custodians of vision, whether they are ophthalmologists or optometrists or opticians, we should remember the goal is not just 20/20 or 6/6 vision or even 6/3 vision, even saying that the accommodation is good and J1 vision, but it is finally to have good stereopsis with good fusion. Remember, we are not just treating sight or stereopsis, but actually we are treating stereopsis and restoring binocular vision and stereopsis. Some of the jobs require precision of depth of vision, like if you have to fly a plane, drive a train, or even do a surgery, as I said. We did a study and on our residents that if they were asked to do simulation exercises and if their stereopsis was impaired by anisometropia, by induced glasses, we saw that the performance drastically drops down. So in children, we need to correct it. What are the challenges? The challenges are, first of all, the realization of the problem of strabismus and amblyopia. Secondly, the loss of binocularity and stereopsis is permanent if it is delayed. So we need to tackle this in early childhood. The loss of vision, which is leading to amblyopia, cannot be recovered fully if delayed. And finally, this also has an effect on the personality of the child. So it will mar his personality or his ability to face people. Remember, God gave us two eyes and they are an asset. In the lower animals, the eyes are placed laterally, so they give a large field of vision to the animal to prevent any attack from behind or the sides. So it saves the animal from the predators which are coming from behind. But the predating animals or the highly evolved animals like the human beings have the eyes placed in front. And this is to improve the binocular vision or stereopsis by the overlapping fields which will share the same visual areas. Remember, how we see binocularly is it's interesting. Now, the half of the field of the world is seen by the right eye, half temporal side and half on the nasal side. And both of these are then crossing over in the optic chiasma, and then they reach the occipital cortex. Now, if you do a microscopic section of the brain of the occipital cortex, you will find the right eye and the left eye ocular dominance columns placed side by side. Now these are the visual inputs which are coming from the right eye and the left eye. And finally in the layer 4C, they are coming together. After that, they become synapsing and form the binocular vision, which gives the depth perception. So in a normal person, if the eyes are aligned and both the eyes are functioning normally, it will give rise to a normal binocular vision. Now let's take an analogy. It's like two strangers coming together. At birth, the child is having the two inputs coming from the two eyes, and these two inputs will share common harmony and they will develop like a normal harmonious marriage. So normal binocular vision development can occur. Another situation can be when the two eyes are not having any common ground and both the eyes are either deviant or there is an alternation of the two eyes. In this situation, it is similar to a couple which is in both the couples are dominant. They keep on fighting with each other because of their career interests. So they are living separately, so to say, or a divorced relationship. Both the eyes similarly will have 6x6 vision, but no binocular commonality or binocular vision. Another situation can be in which one of the couple is so dominating that it overlaps all the fields and does not allow the other spouse to work. And that will be like a situation of one eye dominating and the other eye becoming amblyopic. So amblyopia, if we understand, it is a developmental anomaly of vision. What we mean is that the vision is something which we are evolving with time. We are not born with 6x6 vision at birth. The amblyopia is a situation in which there is a diminution of vision in one or both eyes, despite the best refractive correction, with no obvious pathology of ocular media or visual pathways, and either it is because of a visual deprivation or an abnormal binocular interaction. Finally, the important part of the definition of amblyopia is it can be recovered fully if treated in time. As I said, amblyopia is a developmental anomaly of vision. When we are born, we are having very poor vision, and there is a critical rise in the first 9 months of the visual apparatus, and the grading acuity improves very drastically in the first 9 months, and then gradually up to 6 years, which is corroborating with our visual acuity. Remember, vision is a language, and like all languages which we learn, they are learned best in our childhood. If you are born in, let's say, in China, you will be able to learn Chinese or Mandarin very easily. But if you are in Nepal or India and you have learned your local language, if you have to move to China, it will be very difficult to learn Chinese at later age. Why? Because our learning is best in our childhood. Similarly, the vision is best learned in the first 5 or 6 years of our life. So this paradise of binocular vision can be lost because of amblyopia. And what are the causes of this loss? It can be because of a stimulus deprivation amblyopia. Now, for example, it may be a very high refractive error, uncorrected refractive errors, or a cataract or media opacities which is blocking the vision or image formation on the retina and subsequently reaching one side of the cortex. Another situation may be unequal, uncorrected refractive errors, or if there is a correction given, but they are having different sizes of images as in NIC cornea. Now, both these situations give rise to a competition between the two sides visual imagery, and one of them can be suppressed as we talked about in our analogy earlier. Or a third situation may be a squint or a strabismus in which the two images are going to compete and then one of them is suppressed. Similarly, nystagmus or organic conditions can also deprive the visual development. Now let's take an example of a situation. If there is an uncorrected hypermetropic refractive error that is requiring a high plus correction, and if the child is given glasses, he is able to read. If he is a very energetic type A personality, he is interested in reading, let's say. And if you give him glasses, it will be fine. But if you don't give him correction, there can be a situation when he will try to accommodate with one eye and the other eye goes into an accommodative squint. That will give rise to a strabismic amblyopia. On the other hand, a child may be the lazy kind who does not want to accommodate, and in a situation when the refractive error is uncorrected, he would have a bilateral ametropic amblyopia. So both the eyes are suffering visual deprivation and will have an amblyopia in both the eyes. So how do we assess a child? Assessment of the infant we can make by some simpler mechanisms. One is using the Bruckner's fundus reflex. If you use your ophthalmoscope at 1 meter distance, let it shine on the eyes of the child, you will see a bright red reflex. If there is no fundal blockage, there is nothing, no opacity, then you can see a clear red glow in both the eyes. And interestingly, if there is a esotropia or a convergent squint, then the reflex coming from the nasal part of the retina is going to be more brighter. And this is an indication that there is a squint in addition to the problem of the child that is having. You can also look for fixation preference. Now, if suppose the child is having a squint and he is looking in the first picture with the right eye, the left eye appears to be having an obvious convergent squint. If you cover the left eye, the child is not much disturbed because his seeing eye was the right eye and he is able to see with the right eye still in spite of covering the left eye. But if you cover the right eye, which was his dominant eye, he will not let you cover. He will raise a hue and cry because he is being deprived of sight and he will not allow you to do the coverage of the good eye. So whenever we have a manifest squint and we cover the straight eye and the child does not take a fixation with the deviant eye, but rather tries to remove the cover, it implies that the vision is poor in the eye which was deviating. The vision screening in children, in infants and children, as mentioned by American Academy of Ophthalmology, American Association of Pediatric Ophthalmology, and Strabismus, can be summed up in this table that from birth to 6 months, we look for screening tests like the red reflex test, the corneal light reflex test, that means we see for the deviation of the eyes, or external examination, maybe if there is a ptosis or a cataract which is obstructing the vision, then we have to refer a child for correction of these structural defects and to improve the vision. In 7 to 12-month old children, we can again do the red reflex, corneal light reflex, but we can also do occlusion of one eye and look for fixation and follow movements which are very well established in after 2 or 3 months old child. And then again we can assess for a suspected amblyopia. In still older children, 1 to 5 years, we can do visual acuity assessment and even the stereo acuity assessment by using the age appropriate test. For very small children, if you have to do a assessment of vision, it may be difficult, but you can do it by using teller acuity cards. Now, these are basically grating acuities which are shown to the child. On one side, there is a grating, and the other side, there is a space average luminance background which the child will not fixate. He will try to look at an object which is visible to him, and the observer looks from the pinhole behind which side he is looking. Now, this we have done a study some time back, 20 years back, and we saw that children at around 11 months of age in our subcontinent have a vision of 624 at 11 months of age if they have no problem in the eyes. But if they have a refractive error, the vision drops to 6/72 equivalent. Strabismus will cause a further damage if it is an esotropia particularly. It may lead to a 6/200 vision. And if there is a media opacity like a cataract or a vitreous hemorrhage or a ptosis, it can affect the vision to very drastic levels of 6/2000. Little older children, 1 to 3 years or 2.5, 3 years, we can do Cardiff acuity testing by using the vanishing optotype principle. Recently, we also did a digital automated application using gaze tracking and deep convoluted neural networks, which we presented in the American Academy in 2018 at Chicago by using a digital application of teller acuity cards. This is the algorithm, how it works, and we can work on it to make it more simpler. Now, stereopsis is what? It is each eye seeing the things little differently because of the eyes being placed horizontally at a different vantage points. The disparities between the two eyes, if they are within the fusional limits of Panem, they are fused to give the 3D effect. Now, what the right eye sees is little different and what the left eye sees, and both of them, these disparities, if they can be fused, you can see a stereopsis. So stereopsis we can measure by different tests. For distance stereo acuity, we can use tests like the Frisbee-Davis distance FD2, a distance Randot test, or the Mentor BVAT 2 SG video acuity tester, which is now no more available commercially, or the AO vectographic projector slides, or the Howard Dolman apparatus, which is mostly a research tool. For the near stereopsis, we can test by using the TNO, the Netherlands ophthalmic test, which is very sturdy and very good for stereopsis. I'll show you about that. Titmus fly test, stereo butterfly test, the Randot stereogram test, and also the Lang's test, and simply there is a Lang 2 pencil test. Now the distance Randot stereo test you can see on the left hand side, and on the right side there is a distance Davis, Frisbee-Davis distance or FD2 test, which is a real depth assessment test. These are showing you the near stereo acuity, the TNO on the top, and the bottom left hand side you can see the Titmus fly, and the right hand side there is a rendered stereo test, and the Lang stereo test is another test which can be done for children without using any special glasses. Now, if there is a bedside test which we require in a child, what we can do is a Lang's 2 pencil test. Here, what I'm showing you, the child is holding one pencil and the examiner holds another pencil. If both the eyes are functional, this is possible to be done. But if the eyes are not functional or one of the eyes is covered, you will not be able to touch the tip to tip. And this is a very good test to assess gross stereopsis in a child in a playful manner. So this is a very simple test. All should learn this. If you have a child, now this is the case story of a child born to the famous pediatric ophthalmologist. All of you must have heard his name, Dr. Kenneth Wright. And when the child was newborn, he was having straight eyes. Around 3 months age, the child started turning inwards. And the father noticed that the eyes are turning in. So he did a proper cycloplegic refraction and gave him glasses. And at 6 months of age, you can see with the Bruckner's reflex, the left eye is still brighter, indicating there is a esotropia still in spite of his glasses being worn. So he required a strabismus surgery, which was done by Dr. Kenneth Wright. And at 6 months of age, the eyes could be straightened, and the eyes are straight, as you can see in an older child. And then later on, his normal stereopsis developed, and he can play like a normal child. And that on the right and bottom, you can see a selfie taken with Dr. Kenneth Wright with me. So this is something which we would like to happen to each and every child of our subcontinent. We should observe these children. 4 to 6 weeks, we know that congenital cataract needs to be taken care of. 4 to 6 months, we should pick up an infantile esotropia and correct it by another 6 months or first year of life. And if it is an intermittent exotropia or an nystagmus or a refractive error, we need to correct it in the first 6 years of life so that we can restore binocular vision fully. Now, if a child is having a refractive error and you give the correction, then it is good. If he's having a monocular cataract, we can rehabilitate the child by using an IOL or a contact lens. Idea is that even near ad will be required for correcting the near sight. This child is having a monocular cataract corrected with a contact lens. Now remember, even glasses alone can improve the vision in anisometropic amblyopes, just glasses even without patching. So this is the first step which we need to do. How do we treat amblyopia? First step, as I said, is removing the amblyopiogenic factor, and that is proper visual rehabilitation. Second would be to do an occlusion to improve the amblyopic eye, to get more chance to see and controlling the dominant eye by a patch. Another mechanism can be penalization. We can talk about it. Another would be a cam vision stimulation, which has been described, but not very successful. Pleoptics are also now obsolete. Red filter treatment have been described in books, but not so useful. But the active vision therapy is something which we always add on to the occlusion therapy for the child to use the amblyopic eye more effectively. And finally, the medical treatment in the form of the levodopa or ceticoline is also been used. How do we do the occlusion patching schedule? It can be the full-time patching or a part-time patching. Full-time patching, when we do, we cover the dominant eye for all waking hours. That is what is meant by full-time. And the dominant eye is, or the good eye is covered for full time, full 24 hours or full waking hours. Up to 2 years of age, we use the ratio of 2:1. That means the dominant eye covered for 2 days and the amblyopic eye is covered for 1 day. That means we give a breather or allow the good eye to see on the third day. And this way we will keep on rotating. As the child grows older, then the ratio has to be increased from 3, 4, 5, 6 years old child. We will keep on increasing to 3:1, 4:1, 5:1, or 6:1. That means a 6-year-old child or any child older than 6 years, we patch the good eye for 6 days and the amblyopic eye for 1 day in order to ensure that his good eye is also given some chance to see. But most of the time, that is 6 out of 7 days, the amblyopic eye is given a chance. The other schedule is the part-time occlusion, in which we can patch the good eye daily for 6 hours. That is one schedule, and the other schedule people use for mild to moderate amblyopia is just covering it for 2 hours. But remember, the full-time occlusion works better because it is the concept of the occlusion hours as described by Stewart et al. In the MOTA study in 2004, that 120 occlusion hours equivalent to 1 logmar improvement on visual acuity. So if you are doing a full-time patching, there will be a faster recovery. If you do a part-time patching, the lesser number of occlusion that you do, it may definitely improve, but you will require the patching to be done for longer weeks or months. Then we need to monitor the child every fortnightly in infancy and monitor him monthly after 1 year of age. We continue to do this till about 8 or 9 years of age so that the vision is recovered fully, or when we find that after 2 or 3 consecutive monthly follow-ups, the child is not improving anymore, then we can do it provided the compliance has been good. These are the occlusion patches that we use, or simpler micropore tape. We can make it the patches for more economic reasons. The Pedic studies, there is a small summary I would like to give you. The ATS, the amblyopia treatment study by the Pedic groups, that means the pediatric eye treatment group, and they patched for 6 hours versus full time, and they found that it was similar improvement in visual acuity at about 6 months of follow-up. But remember, in the study itself, they showed that it was faster with full time, and the lines of improvement was 3.16 versus 2.84 lines on the Snellens, which was there between the full time versus part time. Now, ATS2A showed the difference between 2 hours and 6 hours, and again showed that for mild amblyopia, even 2 hours per day may be sufficient. Full time versus 6 hours was shown for severe amblyopia. Remember, if you do not do a monitoring or weaning of the occlusion, there can be a recurrence of the amblyopia. That means there can be people who will have amblyopia again. In 1 year, it is shown to be happening in 21% of children. So we need to monitor these children till about 8 or 9 years of age, or the 8th or 9th birthday, so that we gradually taper the occlusion and monitor them at least weekly basis to see that the vision is not dropping once again. Atropine as a penalization method has found to be useful in children who do not comply with occlusion, and it has shown to be working in at least in younger children. Glasses alone, as I said earlier, work, and we should first try with glasses alone and give a child the improvement possibility, and then add on the patching after 4 or 5 weeks. Recurrence of amblyopia, remember, just to repeat, it is possible, and it can be loss of 2 lines in 21% children, mostly within 3 months time. So we need to always taper the occlusion and do a maintenance patching till 9 years of age. What are changing in these changing times? We are having the cats and mouse games, but now the digital mouse has come. And in amblyopia, has it changed? Or we are still continuing with occlusion alone? Some things have been added. The active vision exercises is one. And the pharmacological modulation, levodopa and ceticoline is another which has also been tried. Pleoptics, which was done in the 50s, 1950s or 40s, is not now prevalent because we can catch the children earlier and treat them with the other occlusion modalities that we can do. Acupuncture has also been tried in a study done from China in Hong Kong. But I would say that this study, which was done in 88 children, they had shown that 2 hours of patching. Now remember, it is only 2 hours, not full-time patching, which was compared with acupuncture, in which 5 sessions weekly for 25 weeks. That means 625 pricks, 5 pricks in each session the child was given, and was found to be equivalent. So one has to think about it, whether the practicality of or pragmatic thing will be there to do so much of acupuncture. Active vision exercise is something which will always improve the occlusion effect, and we can do it by monocular perceptual learning. What we are asking the child to do is play games by closing the right eye and using the amblyopic eye to use the left eye as much as possible, or the amblyopic eye. This can be done with the help of monocular video games, and studies done by our group also have shown that it is helpful. There are some special neurovision type of games which have been done to improve the visual acuity. Recently, binocular vision stimulation is a new paradigm to treat amblyopia. Here, what we are doing is we are asking the child to play video games with the special glasses. That means the right and the left eye would be having different colored glasses, so that the child sees different images of the 2 eyes. So we are moving from the cotton iPads to the electronic iPads. And we have seen that the visual acuity improves in anisometropic amblyopes. Mind you, this is possible in anisometropic amblyopes, not the strabismic ones. And we found that the binocular vision improvement was similar in the group of the binocular stimulation, as well as the occlusion group. But the stereopsis was better in the group in which the binocular vision therapy was given. The dichoptic custom-made action video games, there is a nice study done, published in Vision Research. This has shown that even in adults, with the help of the dichoptic custom-made action video games, we can give a chance of improving the visual acuity in little older children and adults also. Anti-suppression or the binocular stimulation has been done age-old times in the form earlier by synoptophore and chiroscopes, or by using stereoscopes or stereograms, as most optometrists and orthoptists would have been aware of. Earlier, we were using Remy separators for anti-suppression. Nowadays, with the technology improving, we are using dichoptic video games, the VTS4 machine, or the Oculus VR games, using the mobile fitted into this Oculus and improving the visual acuity. This is showing you the VTS4 diagnostic and therapeutic functions of this, and binocular vision exercises can be given to improve amblyopia in people. Just a small video to show you how the vivid vision or Oculus-based vivid vision works. So we can see that the images are split into two, what the right eye and the left eye sees. One seen by the weak eye and one seen by the strong eye. We increase the signal strength of the objects in the weak eye, make them brighter, and make the dimmer in the strong eye, so that we can put them at par and stimulate both the eyes to work together. By the end of the treatment, the patient no longer needs the thing, and the 2 eyes are now working together. And this we can improve the visual acuity by using the new technology. The other situation which is causing the loss of paradise is the misalignment. That means the eyes are deviant. Now you can see in the 9 gazes in this picture, in the primary position, there is an exotropia. On looking up, the exotropia has become worse. Down gaze, the exotropia is less. And on the side gazes, you can see there is a vertical deviation coming. Just to tell you that in different gazes, the deviation can be different. So one has to examine in all the 9 gazes what is happening. And in addition, there may be a torsion or intorsion also happening. So just like we must be knowing about astrology, which are having the 9 planets disturbing the 12 houses of our zodiac sign. Similarly, for strabismologists, it is the 9 houses which are disturbed by the 12 extraocular muscles in the 9 gazes. What is the recipe that we use? First is have a good observation to make, then confirm the problem that you see by simple tests like cover test, infer, plan, and then execute so that we can straighten the two eyes. There can be situations when the eyes are only apparently squinting, a pseudo-strabismus. Now, the top picture showed you a pseudo-esotropia, in which the eyes are appearing to be convergent, mainly because there is a large telecanthus or a broad nasal bridge, and the epicanthic folds are covering the nasal part of the conjunctiva. So it gives you an appearance, especially on looking on the side gazes, that the child is having a convergent squint. But if you see carefully, both the eyes, corneal reflexes are symmetric. And if you do a cover test, you will find that there is no movement of either eye. So it is not a true squint. The middle picture shows you a pseudo-esotropia because of a large palpebral aperture, which is the uri-blephron, which gives you an appearance of a esotropia again. Again, it is a pseudo-strabismus and not a true squint. The bottom picture shows you a pseudo-exotropia. Look appears as if the eye is exotropic, and this is because of a positive angle kappa. Sometimes it can be a nasal drag bridge of the macula, nasally dragged macula, which causes you to see an apparent exotropia. So first step is to give proper correction, and it may be a simple accommodative squint esotropia, and full correction corrects the deviation. The ESO deviation for distance is there in this child despite full correction, as you can see on the right hand picture. Now we need to look further, and we find that with the accommodative target it is getting worse. So this is a convergence excess esotropia. So if there is an accommodative squint, we need to give glasses and also monitor, because the refractive error will keep on changing from time to time. We need to increase or decrease the power as required for the child to correct the squint fully, not only for distance fixation, but also for near fixation. And if this is not done, we cannot achieve full stereopsis for children. So remember, correcting the refractive error is not a one-time job. It has to be done repeatedly, 6 monthly, watching the visual acuity and looking for refractive error every once in a year, so that we can restore the full correction. We have seen that if the deviation can be maintained less than 8 prisms, then only we can have a binocular vision. So we need to have early alignment. The alignment can be disturbed in different ways. It can be in up and down gazes that the deviation may be different. Like this girl has a exotropia, which is becoming worse in up gaze. So there is a V exotropia because of an inferior oblique overaction in both the eyes. This is a situation in which there is an A pattern exotropia with a bilateral superior oblique overaction. Sometimes you will see that the eyes are ortho in primary position, but on looking down, there is a convergent squint, and just looking up in the same child, there is a divergent squint or exotropia. Now, this is because there was a bilateral inferior oblique overaction. And once we see this, we can correct the inferior obliques and straighten the eyes in all the different gazes. The goal is to have a timely realignment. Even in adults, if there is a deviation which is manifest for more than 12 months, as this study done by Fawcett et al. In JPOS has shown that the binocular vision continues to be susceptible even in adults, and if the alignment is not correct for long duration, it can disturb binocular vision. There can be complex problems of strabismus like a third nerve palsy or a Duane's retraction syndrome or a synergistic innervational downshoot. But remember, we can look specifically to each and every problem and correct it by different mechanisms as a strabismologist, as shown in these pictures, that the eyes have been realigned so that we can restore the binocular vision. Conditions like nystagmus can affect the visual acuity in both the eyes, and again we can restore or correct the nystagmus or limit the problem of nystagmus by shifting the eccentric gaze by using the null position shifting procedures or the augmented Anderson's procedure. So in short, I would like to say that we have to be a squintellectual. Look at the eyes. It can be having a refractive error. It may be having a deviation. The job of ours is to correct the refractive error in both the eyes, correct the accommodation problems in both the eyes, and also the deviation in the different gazes so that we can restore the alignment and restore binocular vision. The secrets of success are that we need to catch them early, because that is a time when the binocular vision is developing. We need to do meaningful and permanent gains in older children can be there, but they are more difficult. Presenting vision indicates the severity. We need to get the confidence of the parents and the child for to have a good compliance so that our therapy can be successful. A proper plan of treatment and monitoring needs to be done. We need to guard the regression or recurrence of amblyopia by maintenance of occlusion and having a frequent and regular checkup of these children. Any strabismus needs to be realigned fully and timely. So that is very important. Both the words are important. We need to align them fully and timely. If a partial deviation is left, it is of no avail or no gain. So we need to have a binocular approach. With the help of dioptics now, we can treat amblyopia and restore the stereopsis. Once again, to say that we are not just treating sight or strabismus, but we are restoring binocular vision and stereopsis. The goal of us should be this, and the mission, as I always say, is spreading sight and stereopsis, spreading sight and happiness for kids the world across to maintain the stereopsis and restoring the loss. With this aim, I had presented my NAP lecture, for which I was invited by the American Association of Pediatric Ophthalmology and Strabismus in Vancouver. I was lucky to be the first Asian to be given this honor of presenting the NAP Memorial Lecture in 2016 at Vancouver. I thank you all for a patient listening, my residents and my family who have contributed so much for and I have this book, which some of you might have seen, but this is one attempt to make strabismus and binocular vision problems simpler for all of you. It has been there for 21 years with you all. I thank you for the love and affection that you have been giving and sharing with me. Thank you all.
Thank you so much, Professor, for such a wonderful session. So,
yeah, if there are any questions, we can
now.
I'll just stop sharing.
If you have any question, yes, doctor. Okay. So, participants, I like to request you kindly drop on our chat section.
Yes, Kapil.
Yes, doctor. Right. So I'm going to share the screen as of now. You can see the question on our screen. All right. So this is the first question, doctor. So can you see it?
Yeah.
Yes. Okay.
So basically, for treatment for amblyopia, the phototherapy, by this I think you mean the red filter therapy, which was described, and there have been some studies mostly in the past. Now this was based on the principle that the cones are mainly in the fovea. So people who have, let's say, an eccentric fixation, the red filter would be used to stimulate the fovea, which will be having more cones. So that was the theoretical basis of this therapy which was being done. We have done studies. We have found that this is not very much effective. Now, and we do have much better ways of correcting it by giving the dioptic therapy now that we have, binocular stimulation, which can be done, and using the technology, it can be done even from home. Now, the softwares which can be shared to the laptops, to the children or the parents at home, and they can, sitting at home, they can do these exercises. So the binocular therapy, which can be done for people who have amblyopia, is something which we do. Phototherapy or the syntonic therapy is not something that is being used. Similarly, the optics also was used in the past, and the cam vision stimulation, as I mentioned, was used in the past, but now there is not much role of these exotic therapies.
All right. So thank you so much. This question from the Satyam. I hope he got his answer. All right. Okay. Here is the another question, doctor.
Yeah. So I had mentioned about acupuncture. There was one study which was published in Archives of Ophthalmology, which was done, I think, in Hong Kong. They had done an RCT comparing acupuncture, in which I had mentioned there are 5 acupoints which are there on the scalp, on the neck, feet, and these 5 points were stimulated every 5 times a week for 25 weeks. That means 625 punctures, acupunctures. And that was shown to be as effective as 2-hourly occlusion.
Okay.
To my mind, it appears much simpler to do a 2-hourly occlusion or a 4-hourly or 6-hourly occlusion, which is less painful than to do the acupuncture thing. So
Yes.
my personal opinion would not be in favor of that.
All right. So thank you so much, Doctor. So I guess these were the only questions that raised by our audience till now. So before ending the today's session, Doctor, if you have any good notes to our participants.
So I think these type of lectures that you're keeping, I think it's a very good thing. I really want to congratulate you for doing such a job, which is required, because people may be in distant places and they may be in a setup in which the educational points are not there, or the academic environment is not there. So you're making this possible for anybody and everybody in different places. And now it's not probably restricted to Nepal. It may be anywhere in the world who is going to use the YouTube, which you will be loading onto. So this is, I would like to congratulate that this task is wonderful. And I have seen that you have almost like 130 lectures already done. So that's a very human job. So congratulations to your team, which is doing this job. And that's why I was stimulated to share my little bit also to do this job for you. So
All
people
right.
who are working in the optometry group are to be looking for the vision of children, catch them young, look for the visual acuity, and the squint. Remember, it is not just cosmetic problem. Don't delay the cosmetic strabismus surgery thinking that it is difficult or it will be recurrent or it may be anything. Remember, it needs to be corrected in childhood so that the child has straight eyes, normal binocular vision development, does not have the stigma of having a squint, so his psychology is not disturbed, and he has a normal psychology. So we need to correct the deviations and the vision of a child early, and this was what my message was.
All right. So thank you so much, Doctor. Actually, thank you so much for your enlightening such a wonderful session. And we are so honored by your time and you are, available for us. And once again, thank you so much, Doctor.
Thank you. Thank you
Thank
all
you so much, Doctor.
for listening, and I hope it makes a difference in the practice of your day-to-day work,
Yes,
and
Doctor.
the children are benefited all over. Thank you so much.
Yes, Doctor. Thank you so much, Doctor.
All
So thank you so much. So here we hope you see you all on next session. Thank you so much.